Good morning. Before beginning our presentation, we would like to thank for the kind invitation to join you today from Bologna and Florence. My name is Gubini Giampietro. I am inventor of Gubini system, and my friend is Mario Franchini from Florence. From Bologna, famous not only for spaghetti, mortadella, but also because it's the oldest university of the Western world. And from Florence, on the town of Renaissance and Renaissanistic. And I remember in Bologna my first hysteroscopic procedure. I was in 1980 with my friends Jacques Camus, Ivan Mazzon, Luigi Montevecchi, Luca Mencaglia Tantini, and my friend Franchini from Florence. And from Diagnosis, we came to CN3 thanks to Stefano Betocchi from Bari. And this CN3 approach is today the basis of one-stop clinics, but the limits is the fragments to remove. The limit is the size. The limit is this operative time. And also the in 2009, thanks to technological progress, the mini sector was born. This represents an important moment in the development of hysteroscopic surgery in office setting. And also, Dr. Mark Anuel by hysteroscopic morcellator, but this is my mini resector. Exclusive concept all in one. The possibility to do all diagnostic and operative procedures with the same instrument. Welcome into a new dimension. Why? Because I have two models, the French 16 French oval and 60 French, and no dilatation, non-alteration of on the cervix. The gesture is very easy, and no vaginal instrument, no speculum, no tenaculum, no dilatator, and anesthesia usually not required. At the time is very shorter, also in office setting for use. And the low procedural pain from theater room to office room, the procedural is acceptability make is possible for outpatients use. And but when and how is a correct use possible? Dr. Franchini.
Good day, everyone. I'm Mario Franchini speaking from Florence, and I would like to continue reminding you that we have now a so wide array of scopes and instruments to be used in our everyday life. And the dilemma is which one to choose. This is really a big problem. But I want to stress that we have not to forget that technology is not the only one factor involved in the success of hysteroscopic surgery, but we must take into account other elements that they are balance each other in a close relationship. And this balance guarantees the final result of hysteroscopic procedure in an office setting. And from data coming from meta-analysis and systematic review, we have been proven that performing hysteroscopy with vaginoscopic approach, that means no tenaculum, no speculum, no anesthesia, our scopes, rigid scope, need to be not more of 5 mm diameter. And to minimize patient pain and discomfort, the procedure time shall not exceed 15 minutes. And depending on technology used, the procedure time is reduced by more or less 50%, treating the same size pathology. And there is no close relationship to surgeon skill. Using tissue removal system, the short procedure time required may be explained by the simultaneous cutting or removal of tissue. And because we don't need any additional instrumentation to remove fragments. It's well known that large polyps were generally considered not suitable to be removed in an office setting. But recent data report that the feasibility of office-based polypectomy with 15, 16 French resectoscope or with tissue remover systems could be possible. But until now, drawbacks exist due to the operating time and incomplete removal of pathology using other technology. So the polyp size, for instance, could be perfectly removed with the last generation of technology. And we have not to forget that the total cost of office procedure is markedly higher when we use disposable equipment compared with the usable one. But we have not to forget too, we have to take in consideration that the reusable one have a wear. So we have to change the technology if it is cheaper and reusable. So the main question is still open. Which technology we can use in an office setting, and why we have to choose one instead of another? I think that moving from mechanical reusable scissor and grasping forceps can be considered the first choice, but only when the pathology is less than 10 millimeter. And we know that that kind of instrumentation is simple to use and generally is considered low-cost technology. But some disadvantages are present: the size of pathology and the cost for wear replacing. And when the pathology is larger, that means more than 10 millimeter, the pathology could be cut in fragments. But to reduce time, the slicing into multiple fragments can be done with more performing technology like bipolar or monopolar electrode or laser fiber. But we have not forget that the chips of pathology need to be pulled out of the cavity with the additional instrumentation. Therefore, we lose time performing this kind of removal. We have to take into consideration the cost, and don't forget that to be able to cut the pathology, we have to learn how to perform. More recently, larger polyps could be removed using 16 or 15 French resectoscope with the slicing technique that we are learned with larger resectoscope in operating theater. So it means that we can perform exactly what we are used to do with resectoscope loops. And we have and myoma too could be removed with slicing and cold loop enucleation. As we know, these advantages could be related to the need to drag chips outside the uterine cavity, and depends which kind of system we are using, the cost of disposable loops too. And we have not to forget that the surgeon could be well trained to perform that kind of procedure. Therefore, treating large size pathology help to be treated with the last generation of a mechanical tissue removal system that enable to treat, to remove completely the pathology. And it has been shown that tissue removal systems are effective, fast, and easy to learn. And depending on the diameter of tissue removal system, it's possible to approach to the intracavitary pathology with vaginoscopic approach. Again, the disadvantages are the cost and where replacing depend which kind of instrumentation we are using. And the main factor in our choice is the general diameter of tissue removal systems, because if we are planning to use that kind of technology in an office setting, we have to decide to choose a diameter that is less than 5 millimeters. So I want to close by saying that the selection of hysteroscopic equipment for office procedure must be tailored first to the patient, prioritizing the safety and the comfort. And second, to the surgeon, who must be skilled enough, trained to avoid additional procedure that could be necessary if is not skilled enough to complete surgery in an office setting. And finally, to avoid this, it's important to bear in mind pathology size, the operative time. And after that, we can decide which technology could be used in this particular case, in this particular setting. And the, we want to thank all you for your kind attention, and remember that probably the best choice is to choose the least sensational approach.